we'll get going. So, this session is on cardiac ultrasound. We have Dr. Burhan by Mohammedali. He's a board-certified advanced heart failure and transplant cardiologist, currently working at Sharp Hospital in San Diego. And he's the director of the congestive heart failure program there. He's director of the clinical research of the Cardiovascular Institute of San Diego. And he's passionate about congestive heart failure research, and he's been the PI or sub-PI for many heart failure studies in the past. And outside the work, he loves kids, traveling, etc. We're really appreciative of Dr. Burhan doing this, and so hopefully what we'll do is he's going to demonstrate, get a little bit of technique, and then we'll just 8 by 8 come get 5 minutes of hands-on, see some stuff, and try to get everyone hands-on.
Does he have low EF?
I don't know. We'll find out.
He's being flat, so he's probably not.
It's good. Okay, so thank you very much for coming. So today's session, when I was thinking about it, about the audience we're going to have, and I was thinking about what would be the most practical thing that we want to do. And again, cardiac echocardiogram is like a full training, and we got to learn how to do calculate ejection fractions and look at valves and stuff. And it kind of is a little bit more complicated. How do you calculate ejection fraction, and how do you calculate aortic stenosis and whatnot? So I figured the most relevant thing to do for our population right now is to look at the volume stats, right? And then you hear this all the time. What is the IVC size? Is the IVC large, is it small, is it respiratory variation? And that's something very easily that everybody can do. If you can get your hands on your probe, somebody comes in, they're short of breath, do they have congestive heart failure, do they not have congestive heart failure? You can, as a non-cardiologist, you can look at an echo and maybe say that the heart is not working properly, or maybe it is, you're not sure, but you can very quickly identify to see what the volume status is of the patient by doing quick IVC, which is again very simple. IVC doesn't move, it's a static structure. The problem why heart ultrasound is not with radiology and it is with cardiology is because the heart is moving. Right? So it's moving, and usually you see everything that is static, like brain and lungs and liver. I mean, the entire body is with radiology. So why is heart with cardiology? Right, and really, the only thing I can think of one is because the
Radiology hasn't got
radiology. Well, maybe that, but also the cardiologists invented that, and then they it's a moving structure, and all things are not static, which again radiologists are great at, So hence why cardiac ultrasound has remained with cardiology. So what we're going to do right now is we're going to do a couple of techniques here. Now I don't know what kind of windows we have on our patients. So this is going to be an organic experience with everyone.
Because we'll be able to see better, it worked well.
First thing,
and then we can generalize.
so a couple of things for our general audience is that we want to kind of get an idea of what is ejection fraction of the patient. It's one of the key questions always asked, right, for echocardiogram. What is ejection fraction? Well, we can always check to see if the patient is alive or not, so if the patient is not alive, there's not going to be much to see. The other thing is that if there's questions about what the valves are looking like, in the main valve, we're looking at the left-sided valve, mostly the aortic valve, and the tricuspid, and the mitral valve, and then the other thing there's a lot of things. Any echo usually is about 100 images, so there's a lot of things to look for. But in the interest of time and just simplifying things, we're going to look for 3 things. We're going to try to find the IVC, which is going to give us an idea of the volume status of the patient. We're going to try to get an idea of what the ejection fraction of the patient looks like, then get an idea what the valves look like. Okay, so with that, I'm just going to, do I get this? Can you guys hear me?
The only thing is it won't be recorded if it's not in there.
Oh, okay.
I can hold this.
Okay, perfect. All right, so
run by this, the IVC volume correlate with the probe BNP.
yes, for the most part it will. There are caveats with medicine. There's always caveats, right? Because the IVC size in most patients will correspond with volume status unless you have right ventricular failure, where the IVC is always going to be large because the RV doesn't work. So it will not necessarily correlate with the BNP. But in a regular run-of-the-mill heart failure patients,
So this is left-sided failure.
left-sided failure. Yeah. For right-sided failure, if they have pulmonary hypertension, they have right ventricular dysfunction, right RV dysfunction, then IVC is always going to be large. Because it's not because they're high in volume, it's because the RV doesn't work. Okay. All right. So with that, so I think what I want to do first is that whenever you see echocardiogram, we're going to expose you a little bit. Sorry, right? All right. So what we want to do first of all is that we get an approximate idea of your heart KK register. Okay. So we know the heart is. We all know where the heart is. And the first thing we want to do, we want to kind of get again. You want to make sure you're on a cardiac probe. This is different from a vascular probe. Vascular probes are larger. Can I give a vascular probe? Okay, just to show you what this cardiac probe is smaller. You see, it's more of a square kind of probe. So it tells you this is a cardiac probe. If you use a vascular probe, you're not going to be able to. So this is how this is big and narrow. This is a vascular probe. This is a cardiac probe. So this is what we use to get an idea of what the heart is looking like. So what we're going to do right now, just to put some cold jelly here, just going to get an idea of what we're dealing with heart-wise. Okay. So here, what I'm trying to do, I'm just going to get an idea where is the heart here, to see what we're dealing with. And here.
Burhan, can you mention like the axis that you're on?
Yes. I'm just first of all, I'm just going to get an orientation here to get an idea of where I'm at. So this is what we call a peripheral long axis view. So from the pointer here, no pointer. Okay. So
Apno view apex up here, right?
yeah. So in cardiology, apex is always up.
Right.
Okay. We are trained to read ultrasound upside down.
Yeah, right. That's
Okay.
what we said.
And then also there's two different things. The left ventricle, is always on the right side of the echo screen, and the right ventricle is always on the left side. So we read it upside down and backward and backwards.
Left, right, yeah.
But pediatricians read it right side up. Okay, so pediatric echocardiograms are different from adult echocardiograms because that's how they train themselves. And then so that's the one caveat. You see pediatric echoes, it'll be the heart will be right side up. It'll still be flipped, but it'll still be right side up. For adult echoes, you're looking at upside down, so the apex is up. So when we're looking at over here, is we're looking at
211.
He's in his meeting.
no, I think I just moved this here. Actually, I was just trying to give you.
Look at how the heart's
It's not pumping 150.
It's because
So what are we looking at here?
You're looking at a pumping heart.
That's good. So his heart
You
is
see
beating.
cavity?
He's alive. So he passed the first test. What we're looking at here is the left ventricle,
Left.
and
You see the
here
valves?
is our. There's no aorta.
So here you can use this.
Okay, is that?
Cusps there.
It's not gonna move. Here, I can.
You can see the two cusps.
So, yeah, if we had a pointer, we could just take the point. So what? See the arrow. Where's the arrow?
It's over here, but this is like
Did it move?
I don't know. I feel like if I disconnect, yeah, I don't. If I disconnect it, it'll.
I actually have a pointer in my bag. So hold on.
You can tell me where to point.
Hold on. I actually have a pointer. Yeah.
His heart rate's still the 160s.
160 is not too bad.
Probe is not even
It's not even
connected.
on.
Oh, it's not even on.
Okay. I have a pointer. We got a pointer, guys. Okay.
I thought you had something else.
All right. So
You can see the cavity, the valves, you can see the septum.
So what we have here is that we have our personal long axis view, and what we're looking at, this is left ventricle, okay? So left ventricle here, and what we're looking at over here, this is our aortic valve. You can see just some of it right there.
Right,
I can try to bring it in a little bit more. but not really. Okay, so here, this is the aortic valve right here. This is the aorta you're seeing. Okay? Over here, this is the left ventricle. This is part of the right ventricle which is cut off. We're not seeing the full right ventricle. So we're seeing a left ventricle here, and he's got a good normal, at least in this view, you can see the heart is beating nicely. So you don't have to know what the ejection fraction is, but I mean, most people can tell this is that his heart is squeezing, so he's squeezing and squeezing normally. And remember, the heart
What about
is
the cusp?
a cavity.
Can you tell about the cusps there?
Yeah, not yet. We can't tell the cups here. So here we have, this is the mitral valve that you're looking at.
Right.
Okay? So this is the mitral valve, this is the aortic valve. And you can see that the mitral valve is joined with the aortic valve, right? This is called aortomitral continuity. This is why a lot of times in endocarditis, you will see that patients have aortic valve disease and mitral valve disease. In rheumatic heart disease, you will see they have aortic valve disease and they have mitral valve disease because these two valves are linked. On the other side, they're not linked. On the right side, they're not linked. So again, this gives you an idea of what the heart is doing. Now, what I'm doing over here, I'm just going to switch my hand. It's going to stay over here. I'm just going to rotate this a little bit. You see, look at the probe rotating. And now we went from an oblong heart to a circular heart. You see? So what we've done now, we've kind of gotten rid of all our valves and everything. But what we're looking at over here is we're looking at the heart. It's cut as a cylinder. You know, the heart is a cylinder. So now you're cut like a donut, right? So you're looking at a donut here. So you're seeing all the walls kind of coming in, and squeezing over here. Okay? And this is a good view because what we can also do, we can try to, just by tilting, look, I'm not even moving the probe. I'm just tilting my hand a little bit, trying to see if I can get the mitral valve in there, and I can see it's coming in right there. And now what you're seeing is you're seeing the mitral valve, and we lost it there again.
Can you show us what?
Yes, we lost it. So let me try to get it again. We're gonna get some more gel here. So this is looking at parasternal axis views. These are called parasternal. Well, they're done from the top over here. Okay. We're turning here, and we find the circular heart right here. And now you can see the valve, the entire mitral valve coming into play. You see this? It's like a heart-shaped valve. You can see the two cusps of the valve. And let's see if I can bring it in focus here. So here you see both of them. This entire thing you see here is the mitral valve, the circular valve. So you see the entire orifice of the mitral valve. Earlier, when we were doing this view, we were just seeing the side leaflets of the valves right there. Now we're seeing the entire valve over here, in short axis. So now you're seeing the entire circle of the valve. This is where the blood enters from the left atrium into the left ventricle. Now what we're going to do, we keep on tilting. We keep on tilting our probe, try to see if we can get the aortic valve in view. And here is the aortic valve. You see it right there? And you can see the Mercedes-Benz sign. It's upside down right there. Okay, one cusp, second cusp, and coming down here.
Tricuspid.
Okay, there's a tricuspid aortic valve. We can try to see if we can bring it further into view by moving our probe a little bit. And sometimes we may get it, sometimes we may not get it. So we're not getting it.
The two valves together?
Yeah, so here what you're seeing, you're seeing the mitral valve and the aortic valve. You're seeing the continuity again. You can see the circle here is the aortic valve. I'm trying to bring it in focus right now. We're frozen. Let's unfreeze. And back to our original view that we saw, the ventricle, and then move this probe a little bit to make it circular. Make it to a donut. There's our donut coming in. And then we're going to try to see if we can get the aortic valve here, if we can. Take a deep breath in and hold it. Hold it.
This is an axial view, right?
Yeah. So this is again, this is all parasternal views. So you can see the aortic valve, but not, earlier we were able to see the three leaflets, right now we're not able to see the three leaflets on it. So, I'm gonna gel this guy up. We're gonna need a good shower after this, but it's okay. Again, we can see the donut right here. We saw the mitral valve earlier. This is it. You're looking at the apex of the heart here. You see the heart getting smaller and smaller and smaller. Now it's gone out of the picture. Okay. So now we can see the heart getting bigger, 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 bigger. Let's see if we can get the aortic valve. There, so that's the aortic valve right there.
At the bottom of the screen, is that the aorta?
Yeah, so he's looking at the aorta right here. This is the aorta going out. Okay, so maybe we won't spend that much time looking for the aortic valve. We get the idea here.
Any thickness per kari sako છો? Ventricular thickness per kari?
You can measure ventricular thickness and everything. All of that measurements are done in this view. So they're usually done in the parasternal long axis view. This view over here, when you get the ventricle in an oblong shape, you measure the thickness. You measure the LV septal thickness right here. This is the septum you're seeing. And then you also measure the inferior wall thickness over here. You can measure the aortic size over here. How sometimes in echo they tell you that the aorta is enlarged or what have you. You get all of that from this view. So, I think for some reason I can't get his aortic valve, and we see it, but I can't see the nice crisp image of the aortic valve. I can see it on Mercedes-Benz sign, and we somewhere I would see it over there. So I'm going to move on. So preparatory view, again, this kind of gives you an idea of what the heart is looking like and how it looks like. Now we're going to move to apical views. And this is, again, apical views are good because this is where you can look at all four chambers of the heart. So how many views are there? There's a lot of views. So there's personal long axis views, and then there's personal short axis views. An apical 4-chamber view, apical 3-chamber view, apical 2-chamber view, and there's an apical 5-chamber view, and then you move to subcarsal views, So there's within these views there are sub-views as well. Okay? So apical views are usually obtained where the apex of the heart is. So if you think about him, his heart is over here, his apex is probably sitting somewhere over here. So what we're trying to do, we're going to try to put the probe around there to try to see if we can get the heart in focus. And a lot of times what happens is that if we turn you towards this way, then the heart drops, then we can get it more lined up here. So we can try to see if we can get anything from this view. If not, then, and sometimes the depth needs to be adjusted too. Where's the depth here? Where's the depth here? I'm just trying to get the probe to go deeper. And we can see that there's something moving there, right? So again, it gives you an idea that we're looking at the moving structure. So now I just have to get his heart in there. I should please clean all the patients here beforehand. So patients have windows. Some patients have good windows, some patients are not. Here, see, so he doesn't have great windows, but we can. Can I get you to turn to the side and lay down this window? Just turn it like it would be exactly. Alright, so here we are. You see how that changed the same view completely? So what we're looking at here is looking at the upside down view of the heart. And on the right side, the big structure that's moving, that's the left axis.
You get a flat like this. You can, yeah. I can see it.
Right. Go ahead.
Can you talk?
Hello? Can you hear me? All right, good. So we're going to try this again. All right, so what we have here, again, from this angle, but earlier, because he was sitting this way, the heart was quite not coming in picture. But now that he's actually moved this way, the heart is dropping a little bit, and now we're able to get a perpendicular axis of the view. So what we're doing over here is that we're just going to take, so we're just looking at his chamber here. And let me see if I can get what's a depth a little bit more.
Yeah, color.
Yeah.
Let's remove the color.
Remove.
Yeah, remove color. Okay. So, so what we're looking at over here, on that side,
This has got a good mitral valve.
so on this we're looking at the right ventricle over here. When we're looking over here, we're kind of going in and out of because breathing, and then we're looking at the left ventricle over here. Right? And then we're also looking at the mitral valve here. And we're looking at the left atrium over here. Okay? So now, let me try to see if I can get a better image of this. And here we get a better image. So you can see the right ventricle is coming into view. See there? It's the right ventricle here. You know, upside down, right atrium over here. This is a tricuspid valve right there. Yeah? This is the mitral valve, which is again very good. See it opening, closing? So you don't have to be a cardiologist to know this is actually a normal looking mitral valve. You can see how widely it opens and closes. You see the LV is kind of squeezing very nicely. You see the RV over there, which is kind of trying to get out of the view every time because half the RV is hidden behind the sternum. So it's sometimes hard to get the entire RV. But we're trying to get as much as we can. We can kind of see things kind of moving. And you can see that the base of the heart is moving up and down. So you can see that atriums are getting larger and smaller as every heartbeat. See that? So, and then here we have the aortic valve opening right there. You can see this is the aorta coming out of the left ventricle. So again, you know, what you're trying to do, you're just trying to get an appreciation of what this looks like.
To the
Here,
left, it would be the tricuspid.
this is the tricuspid valve right here. This is the mitral valve. And now this is a good place to start doing some color Dopplers. If you could help me, thank you. So let's put color on the mitral valve. And what the Doppler does is it uses the same principle of physics. Take that. It's just a color. So it uses the same principle of physics that if blood is moving towards your cone, there'll be a color change compared to if blood is moving away from your cone. Okay, it's the same thing when you look at stars. When you look at stars in astronomy, and I'm an amateur astronomer, so it's very, very near and dear to my heart, is that stars that are actually moving towards us are red. Stars that are moving away from us are actually blue, because this is a Doppler shift principle. So same thing, we can apply the Doppler shift principle for blood in the heart. So you can see that it's both blue and red over there. Okay, let me get this in the focus again. Perfect. So you see red is blood going down from the atrium into the ventricle. You can see this one flame of red going down. And then another blue flame appears. You see this blue flame? This is blood leaving from the ventricle into the aorta, trying to go out of the body. Okay? You guys appreciate the blue, red flame right here? Red flame? Everybody see it? Anybody not see the red flame?
Everybody sees it.
Everybody see it. Okay, everybody see the blue flame?
Yeah.
You see? Now, if we had valve problems, we would see this, because this is, again, an open valve, so blood is flowing very linearly and just go down, and there's a single net vector of blood going down, and a vector of blood leaving the heart. Now, if he has mitral stenosis, you would see all kinds of colors over here. You'll see yellow, blue, green, everything, because it's just kind of, blood is just trying to go this way, that way, that way, that way, trying to get into the heart. So that, when you see a lot of turbulence, that's what they call color turbulence, that suggests there's some issue that you need to investigate further. Which again, the sonographers are very, very, very familiar with, and they know what to do about that. All right? So, and then this is also a place that we can actually do with an actual tissue, actual Doppler. And the Doppler kind of gives us an idea. Can you do this? Yeah. So this is again, this is a Doppler, and yeah. Okay, perfect. So you see this right here? You can see these triangles going down?
So,
Yeah, that's right. I think probably we've got, let me get it in focus here a bit more. So you see this triangle right here? You know, so this is telling us the blood leaving the heart. This is telling us blood entering the left ventricle. Okay, and this again is called, this is a PW, which means that we're actually looking at the mitral leaflets right here. So we can see the first phase of blood entering and second phase entering, and then here the valve is closed and again it enters. So because you have the atrial contraction, and then so you have the ventricular relaxation. So if you think about it, when the mitral valve opens, let's freeze one of these. So, no problem. So here what we're looking at here is that you can see there's one mountain right here and the second peak, right? So the first peak over here is giving an idea of blood, of mitral valve opening and blood just going in by itself. And the second peak is when the atrium contracts, it fills up the ventricle. So it kind of gives an idea of how the filling pattern is. And this is how we judge diastolic dysfunction. So a lot of times you get echo reports, they'll tell you grade 1 diastolic dysfunction, grade 2 diastolic dysfunction, grade 3, whatever. This kind of gives the first idea of what diastolic dysfunction is in this patient.
So if there is diastolic dysfunction, you would see the second peak distant.
Well,
or low?
so when you have diastolic dysfunction, what this would show you is that, so this by itself is not enough. You need something called tissue Doppler to tell you that what kind of diastolic dysfunction there is. So
Just to grade it.
again, it's grading, yeah. So first thing is that when you see this is a normal pattern, a normal pattern can be either normal, but they also call about type 2 pseudo-normal, which looks normal, but it's really not normal. So this is why we need tissue Doppler, which this is not the scope of today's workshop, but I can just show you what tissue Doppler looks like. So, can you do tissue Doppler?
Kalakman nahi kari saka echo fellowship.
Focus echo fellowship.
Be ready for the echo.
So let's do tissue Doppler.
Color?
No, tissue. You have tissue Doppler on this one? No. I don't think we have tissue Doppler on top.
CV.
You have CW, you have
CW.
You don't have tissue Doppler here. So this gives an idea of our apical views, right? So we saw that there's this 4-chamber view, and if I turn the probe a little bit, I can move the left ventricle because this is a 2-dimensional structure, right? We're doing a 3-dimensional image. We're doing a 3-dimensional object. The heart is a 3-dimensional object on a 2-dimensional plane. So we're looking at two walls at a time. So what I can do, I can just keep on turning this probe and try to get other walls of the heart to get different other wall in the image. So now here, what we're looking at, I just turned my probe a little bit, and you guys can all practice here a little bit. And now we're looking at this is a 2D. This is a apical 2-chamber view. So this is looking at the inferior wall and the lateral wall. Then we can also do an apical 3-chamber view, which is looking at the inferior lateral wall and the septal wall. So in that way, we're looking at an entire 3-dimensional image of the heart in individual 2-dimensional planes.
Quick question.
Yes.
When you say the inferior view, you mean the apex of the ventricle, or when inferior you mean on the image?
No, so the heart's walls have names.
Okay.
So there's like the anterior wall, anterior lateral wall, inferior septal wall.
So
septal,
inferior,
so those are
so those are
walls,
the,
yeah,
okay, so
not in terms of
image,
where,
not where
we
we
are
are.
in the image. Exactly.
Yeah.
Exactly. Okay. So in this way, we can kind of go through around and just kind of look at it. If you had a wall motion abnormality, you're like, oh, this person had a heart attack. You want to look at inferior wall, and you can just turn around and look at it and get an inferior wall idea. Okay. Now let's flip you back to your back, please. Now what I'm going to do is I want to again wrap this up with subcostal views. In the subcostal views, we're looking at inferior vena cava. So the subcostal view is easy. What do you have to find? You have to find where the sternum ends. Okay, so you put the sternum ends right there, and this is the point where your probe is going to go to look for the subcostal view. So this is subcostal views, and the probe is parallel to the probe is going to be parallel to him. So what the general indication here is that you're going to start seeing the liver first, and that's a good deeper. We're just going to depth here. Oh yeah, perfect. Okay. All right. So. So what we're looking at, we're looking at the heart now, but you remember when we saw it in the 4-chamber view where it was upside down? We're essentially looking at a similar view, except it's cut that way. Okay, so if the heart is sitting here, I just cut it this way, and I'm looking at it from the top, and I say, oh, what does your heart look like if I just cut it? So I slice the heart from the top to the bottom, and what we're looking at here,
Would you say that's like a coronal?
this would be coronal equivalent, yes, yes,
So just
exactly.
that people can understand,
Yes,
it's a
yes.
coronal equivalent.
Yeah, I wish I had brought a hard model. Next time we'll bring a hard model, so it'll be easier to see what they're looking at here. All right, so what we're looking at over here. Okay, so you can see that, so here, there's a different kind of structure. You see this thing? It looks different, right? This thing here, that's your liver. You can see the texture of the liver is different from other tissues. You see, if I just put the probe over here, this looks different compared to over there. Okay, so this is the liver. So what you're looking at the right atrium, right ventricle, which is right next to the liver over here, and this is the left ventricle. Right, and then here is our right atrium, and what we're trying to do, we're trying to bring in the inferior vena cava in this image. Let's go deeper.
I just figured this next 15
We're
minutes.
gonna, yeah, okay. We're gonna finish up, and then you guys can scan it. I'll get all the, whoever doesn't like you, can get maybe not with you. So.
Inferior ventricular.
His heart went to 179 or so.
Yeah, the heart rate, I don't think is accurate. But
It's probably higher, right?
yeah, we're not gonna be doing echo with our own head. We're gonna be doing actual ACLS crash course here. Okay, so I'm sorry, I might be squeezing. I'm pushing a little bit harder on you. Okay. All right, so I'm just trying to see if we can get this in him. Get a big meal? Sure. Okay, so,
Turn the gain up a
so
little bit.
here we can, this is not very clear. But
I just turned the gain up a little.
yeah, you can increase the gain, yeah. But I think we just don't have a good. So we can see here, there's something entering the heart right here, right? You can see that? And I'm trying to bring it into focus here, so I know where it is.
Inferior vena cava.
Yeah, so it's usually you get a nice clear picture of it, not in head without getting it. So we can see something entering the heart, which is the inferior vena cava. Yeah. Right here. Now usually you'll see a nice clear. Okay, there we go. Perfect.
Collapse device.
Collapse there. So the funny pyramid. Okay, anyway, so his is right. So we only see a little bit of it right there. It's very small. That's why we don't see. Usually, if it's heart failure patients, they're full of volume. It's going to be big, giant size, about 2.5 centimeters. I think he's probably not even going to be like 1.5 centimeter. So it's going to be very small and completely collapse. Just by pushing it down, it collapses. So he's like just a normal guy. Unfortunately.
Raise up his legs.
Yeah, we can do that, right? Yeah, we can raise his legs, and then he's going to be like all plump.
Yeah.
All right, so in the interest of time, let's just practice some scanning. Whoever wants to scan, you can just put your hands on the probe and just kind of get an idea of how to, just get some images and stuff. You can go from there. So you want to get peristernal views. This is the view that we saw earlier. Now the depth of the view over there, you can already see it. So now what you're seeing here, this is a short view, yeah, exactly. If you just go up a little bit, right there.
Intercostal space?
Yeah. You can go up to second intercostal space. Yeah, and again, because the heart is different in everybody in terms of how high it lies, and you can go up and down. So what you're looking here is you're looking at the view that we saw earlier with the aorta. This is the peripheral wall axis view. And I think your probe is on upside down, so we're trying to probe this way. This light should be on the other side, so this way. Okay, yeah. So now, see, so what you're seeing here is that you're seeing the donut here of the heart. Okay, and then to do this. Yeah, so now you're seeing the view earlier we saw. And this is the left ventricle right here. This is the aortic valve, the mitral valve, and the right ventricle. You know, so you're going to get it here, and then you can do you turn it a little bit back, do it back to donuts right there. Go back to the donut. Open it now. You can sometimes you can go down too. You hold it over there. Hold it like that and just play around. Now you can see the aortic valve, the aorta right here. This is the descending aorta right here. Okay. And this is the aortic valve opening and closing. This is the mitral valve opening and closing. This is the right ventricle.
Mitral effects are seen much better.
Yeah, because they're much closer here in this view. Close. Usually the mitral valve and the
Aortic valves are for around.
usually you'll see them, yeah. So, keep some going here. Now, if you just turn this a little bit, there are some longexes here, where you were earlier. It's new here. If you just keep it there, but just turn the probe like this. Very slight movements, see? Keep on turning slowly. Now you're changing it from the oblong to a circular view, you see? And you keep on going this way, now it's circle. Now you see the mitral valve showing up in a complete mitral valve. Instead of just two side leaflets, now you're seeing complete mitral valve, you see? You keep on going, yeah. Right, and then you turn that this way, and then if you do, once you get the donut,
Can you see the cusps with deeper penetration? Can you see the cusps with the deeper penetration?
you're already seeing the cusps. You know, we can go deeper, but you're already seeing the cusp right now. I mean, you're not going to see crisp cusp. You know, for that you need TVs. For the transthoracic, because the mitral valve sits in the back of the heart. Yeah, so you're right there. So you got the paraceal lung axis view that we learned about. Okay, let me increase. Just stay right there. Okay. So, okay, now this gives you an idea of, you know, again, this is your aorta, the aortic valve, the mitral valve. The left atrium is pushed a little bit, and then here's the right ventricle. The right atrium does not exist in this image. Okay, and then when you turn this just a little bit like that, then you'll get, again, you can see a little more valve, and you keep on turning. Now you get a circle. See that? Circle, and now you see the mitral valve completely as a full circle right there, opening and closing. Now, if you have rheumatic mitral disease, this would not be, it would be very small and would not be opening properly. Okay? And then if you just keep on going like this, just in the same place. You see now here, you're seeing the aortic valve. Earlier we saw this picture when I would see all three cusps clearly. And you can see there's one cusp right there, there's another cusp right there. Another cusp is hidden over there. This is the aortic valve. But you can, there, you can actually see Mercedes Benz sign right there. Upside down Mercedes Benz. Not crystal clear, but it's right there. Yeah. And then you can play around from here, from the side, you get all four of them, all four chambers. Now you're further down. You're seeing the end of the heart.
And you can see the two chambers.
Because you see, the common misconception is that the heart is like this. Okay? So the heart is actually not straight down. The heart is sideways. That's one. Plus, there's another thing too. It is rotated inwards. You know? So what you find is that you find the left ventricle in the back, the right ventricle in the front. You know, so that's why in that probe, in the first view, the first thing you see is the right ventricle.
Pay attention to the ventricular septum definition.
Exactly. You're seeing the ventricular septum right there. Yeah. Next.
Good job, Nomanda.
No?
Good job.
Yeah. So,
I'm a cardiologist, so I can't actually.
No, you did great. I'm still trying to orient myself.
Forget about it. Yeah. Yeah, I mean, the good thing is that you have a great heart. You know, yeah, your heart is, yeah, you're getting like so many people like that. It's on your leg, you have got a right ventricle right here. And this is the left ventricle, the mitral valve, the aortic valve, the picture right here. The second well, there is this is a descending valve. This is your aortic valve, the mitral valve, that's right there. Exactly. So you see right ventricle is the first thing, and then you see left ventricle. All right? And then if you turn this like this, then it seems to go up in the whole ventricle.
See that here in the chart?
Not in this view, you'll have to see it in the typical view. You see what?
Just to give you an idea, 5 minutes.
5 minutes? Okay.
Dr. Brahma, quick question.
Yeah.
Would it all be possible to see calcification ultrasound?
Not on ultrasound. If you're very lucky, sometimes you can see this to take off the right atrium of the RCA. You know, and if it's a very calcified plaque, it might cause shadowing, but that's only the beginning of it. You can see. You can't see the rest.
And what about the pericardium here?
Very bad. Yeah, you can see the pericardium. I mean, most people you're not able to see the pericardium because it's very thick.
Unless there's
Yeah, unless there's some fluid, or if pericardium is thicker because of
more like a
you see,
deep
you
or
can
white,
see,
right?
Yeah. This here is the pericardium.
pericardium right there.
You can see every kind of figure. You can see, so if you had somebody with pathology, you can see all that stuff.
And then layering by alag here.
Yeah. So in fact, if there's any, so most people have just a trivial amount of fluid. So you can see the best place to see the pericardium would be in the subcostal view. You know, so let me see if I can get a pericardium because he has some images here. Okay, so here, so you're not seeing much of the pericardium here, but this is kind of like it's surrounding it over here. This is the best image to see it, but he has it, but it is not easily visible.
All these bubbles is the cocoa.
This is not bubble. This is liver. This is the liver here. You see how this looks different? The liver is completely different morphology. You can just look at it.
Yeah, the Coca-Cola in the liver.
Yeah. You want to drink the liver?
One question. For the internal medicine,
So
internists,
you're going to start up here to get yourself a good
How
orientation.
useful is this
Doppler is prepared, but you can do
echocardiogram for
whichever.
getting like this?
So you are, so, there you go. And you're looking at the aortic vein right here. So now you're looking at the mitral valve here. So you look at descending the aortic vein. Yeah, and then you look at his right ventricle. So you look at oblique here, a little different view than what other people like that. So you can see that the aorta is kind of like, instead of like this, it's kind of like that.
No, but from that your own muscle.
So your papillary muscle,
No, it's just right
the
before.
papillary muscle,
Where is it?
here's your papillary muscle right here. This is kind of like a hybrid four-chamber slash yeah.
Yeah.
This is like a the right ventricle is, you're not going to see elliptical. Because of the way that would be situated. The right ventricle, you're going to be in the same place where you are here. We're just going to turn the probe. So you got that? So you have to get the mitral. So you see the mitral recess right there, right? Now turn, now just keep on turning.
With the probes?
The transducer.
Oh, so that's not included. Thank you.
All right. Anybody else? Do we have a volunteer here for 5 more minutes? You know, we should torture him. Yeah, this volunteer, you know, he's he's asking to be tortured, you know, so why not?
I think everyone should check an IDC.
I know, everybody's checking IDC. Yeah, so this one is going to be the national line. She's going to start this one. Nobody wants to do apical, huh? Can you pull it down so you can go up? See? The right ventricle, left ventricle, mitral valve reflex, left atrium, aorta, aortic valve right there. Descending aorta, going back down. Pericardium too. Yeah, you can see it from there. I want to see the forward. So you have to go for the roll to go for the So you have to go. Let me give you some jelly because I think we're in this. Okay.
1 minute, guys. I'm gonna have to switch, unfortunately.
We were trying this. So people where the heart is visible, right? So you want to be at the plane of the heart, so you have to go. You turn this way. But I think in him we found that if he turns towards us, that's when we actually get it, remember? So let's see if we can get anything in between without turning in. Yeah, unfortunately. So you are, look at the landing. Perfect. There you are. You see, now you see the entire left ventricle right here. This is the septal wall that we're seeing. The right ventricle cut off a little bit. The aortic valve, mitral valve, the atrium, the same device. You get what you get, don't you? Go for it. Now you see the donut.
That's a descending aorta?
Yeah, it's a descending aorta. No, yeah, we're good. Thank you. No worries, no worries. Well, let me wipe off the. Yeah.
Burhan bhai, I want to thank you for doing this, and Ali bhai, shukran for being a patient.
Volunteer. The cultured volunteer.
So in next session, renal, maybe urinary bladder, but renal ultrasound.
You good?
In like 5 minutes, inshallah.
I already got one.